Hello everyone. So today we will talk about diagnosis of ILD. So to make accurate diagnosis of ILD, we need to get enough information from history, chest image, pulmonary function test, bronchoalveolar lavage, systemic examinations. Sometimes we need lung tissue biopsy. MDT. This is multidiscipline team to make a definite diagnosis. So the history, we have to pay attention to the duration of history. Although the rate of symptomatic progression and physiological deteriorations for the individual patient with ILD is variable, it generally runs a chronic course that range from 6 months to the time of diagnosis and up to 10 or more years, depend on the specific etiology. For the age and gender are sometimes useful in the general evaluation of ILD. So between the age of 20 and 40, sarcoidosis, collagen vascular disease associated ILD, and the familial form of idiopathic pulmonary fibrosis are more likely to occur, and above the age of 50, IPF must be considered. So for the most other etiology of ILD, there are no age and gender consideration. And there are few exceptions. So women are sometimes more likely to have collagen vascular disease associated ILD and LAM. And for men are more likely to have pneumoconiosis, although asbestosis have been reported to cause bystander pneumoconiosis in wives and children of workers who are exposed to contaminated clothing. For the occupational and environmental history, a detailed lifelong occupational history must be obtained. There are an extensive and growing list of antigens, both in the workplace and in the home environment, that can cause hypersensitivity pneumonitis. And drug history is very important. Carefully, drug history must be obtained. Patients often neglect to mention past medication take for prolonged period. In most cases, the onset of the drug-induced ILD is temporarily related to the administration of the drug. And a drug effect from other radiation treatment or the inhalation of high concentration of inspired oxygen associated with diffuse alveolar damage is associated with biomethane and other lung-toxic drugs. So in some cases, family members also have ILD, so we should pay attention to the family history. So symptoms for the lung is shortness of breath at rest or aggravated by exertion. Dry cough, so we have to pay attention to X-ray pulmonary manifestations such as joint pain, morning joint stiffness, digital edema, digital fluorescence such as magnetic hands, and weight loss. For the extrapulmonary physical examination, we should pay attention to the skin. We also can see rashes, cyanosis. And the hand, you also could find Raynaud phenomenon, climbing fingers. And for the lung, you can see vacuolar crinkles in auscultation. For the laboratory findings, normally we can find hypoxia. So PaO2 is low. So the IgG, IgA, IgM sometimes are positive, and about 20% to 40% ANA will be positive, and about 10% to 20% the rheumatoid factor would be positive. And sometimes, if you find ANCA positive, would be pulmonary vasculitis. So there are many important diagnostic antibodies in the blood. So the serum angiotensin converting enzyme, we call SACE, often indicate sarcoid disease. So if you find anti-neutrophil cytoplasmic antibody, we call ANCA, indicate vasculitis. And for the antiglomerular basement membrane antibody, that is AGBM, often showed Goodpasture syndrome. And some connective tissue disease has special antibodies in serum. For example, so SSA and SSB positive often showed Sjogren disease. For the RF and CCP, often showed arthritis purpureum. And dsRNA, DNA, and anti-SM often showed SLE. For the GO1, SRP often showed multiple myositis. For the ACL70, often showed systemic sclerosis. So this picture shows how to perform pulmonary function test. So this test is very important for the revolution. So this picture shows how to perform pulmonary function test. So this test is very important for evaluate ILD. The test requires you to exhale quickly and forcefully through a tube connected to a machine that measures how much air your lung can hold and how quickly you can move air out of your lungs. It also measures how easily oxygen can move from the lungs into the bloodstream. So people with interstitial lung disease may have a reduced lung compliance. They may also have a decreased ability to transfer oxygen from their lungs into their blood, indicated by decreased diffusing capacity for carbon monoxide, that is the LCO, and showed restricted voluntary lung defeat, decreased of vital capacity, decreased of residual capacity, decrease of total lung capacity. The chest image is key to the diagnosis of ILD. So a high-resolution CT scan can be particularly helpful to determine the extension of lung damage caused by interstitial lung disease. And it can show details of the fibrosis, which can be helpful in narrowing down the diagnosis and in guiding treatment decision. So you can see different shadows in the interstitial ILD lungs, such as small nodulars, patchy shadows, cystic airspace, linear or reticular opacities, ground glass opacities, and honeycombing. So this chest radiography showed the bilateral linear or reticular opacities on the lower part of the lung. So chest radiography is usually in the first test to detect interstitial disease, but the chest radiography can be normally in up to 10% of patients, especially on the disease procession. So this is the chest radiography. So this is the CT scan. So this CT scan showed small nodules in the both lung. So this is hypersensitivity pneumonitis. And this picture shows the basal and subpleural predominance reticular pattern with associated traction bronchiectasis. And this is IPF. And this picture showed cystic airspace in both lungs. This is PLCH, so pulmonary Langerhans cell histiocytosis. So this picture showed patchy saddles in the left lung and the consolidations in right lung. So this is COP, cryptogenic organizing pneumonia. And this picture showed ground glass opacities. This is AIP, acute interstitial pneumonia. And still, we need bronchoalveolar lavage. So when use bronchoalveolar lavage analysis, if the percentage of lymphocyte increased, that could be sarcoidosis, hypersensitive pneumonia, lymphoma. So if the percentage of morphonuclear leukocyte increased, that could be IPF, familial pulmonary fibrosis, asbestosis, or AIP. So this picture showed how to perform bronchoalveolar lavage. Doctors inject saline into right middle lobe through a bronchoscope and then immediately suction is out. The solution that is withdrawn contains cells from the airspace, so we can analyze this. So bronchoalveolar lavage samples might provide information to diagnosis of pulmonary fibrosis. So the picture in the left shows the normal color in barf is similar to saline, and the picture in the right showed milk-like barf, which is indicate PAP, that is pulmonary alveolar proteinosis. So sometimes we need to obtain lung tissue to examine under a microscope. It's the only way to determine which type of interstitial lung disease a person has. There are several ways to collect lung tissue, which is called a lung biopsy, including bronchoscopy, that is transbronchial lung biopsy, we call it TBLB, and we could do open lung biopsy. So now more and more people will go to video assisted thoracic surgery, that is VTS. So this is all the methods to diagnosis ILD. So thanks a lot.